8-year-old Danosiata Kahara, a resident of Kichwamba village in Ibanda Parish, Nyarushanje sub-county in Rukungiri district, southwestern Uganda, is a beneficiary of the Kisiizi community health insurance scheme run by Kisiizi Hospital, a Church of Uganda-founded health facility. Kahara is enrolled on an annual premium of 41,000 shillings. In May last year, she was diagnosed with uterus cancer and doctors recommended a total abdominal hysterectomy, a surgery that involves uterus and cervix removal. Kahara told me she's feeling much better now.
She would have died. It would have advanced beyond the uterus, it would have spread to the rest of the abdomen and even to further organs of the abdomen, and she would eventually die.
Kahara made a co-payment of 500,000 shillings for the surgery, a varying figure insurance administrators say they put to prevent members from abusing the scheme. Kisiizi Community Health Insurance Scheme enrolls about 40,000 residents. While the scheme does not cover all forms of illness, figures have shown that it has prevented catastrophic health expenditure, lowered rates of death, malnourishment, and admission.
And we believe that this is because people attend the hospital earlier in the course of their illness before they get so sick, whereas those who are not members may try other modalities and then they present much later in the course of the illness when they're more serious and they're more likely to need admission.
Here is how Kisiizi does it. In the early 1990s, the community here had burial groups called ngozi, meaning an improvised stretcher used to carry a dead person.
So we saw the idea that how about, instead of waiting for the person to die, why would you not pay money up front to the hospital, and then when a member is sick, then you can comfortably walk into the hospital and get treatment.
Ngozi community groups have since been modified into 213 insurance scheme groups consisting of 2,418 families and 38,353 members in Rukungiri and 5 other neighboring districts. Each group has a leader responsible for its members' premium collections. The group leaders are represented by a 16-member executive committee working as a go between the groups and the hospital management.
This executive sometimes has meetings with the hospital management. From there, the executive invites the group leaders, they tell them the same, so that the group leaders can take the same information to the last man in the village.
It is difficult to market an insurance scheme as there is no legal framework regulation allowing hospitals to advertise health services that involve payment. This has left many out, but there are also skeptics. The very poor are being helped under the hospital's Good Samaritan bag. This is an equivalent of the clause in the National Health Insurance Scheme Bill that caters for indigents who would not be required to pay for services. Bwindi Community Hospital started a somewhat similar plan in 2010 and has grown to cover 204 groups with 27,022 beneficiaries, which forms 34% of the plan's catchment area. On March 31, 2021, Parliament passed a National Health Insurance Scheme Bill that would, if assented to, require 60% contribution from employers and 40% by employees, but none of the parties were willing to contribute. The bill was then returned to the Ministry of Health for further scrutiny.
They fear that it would be difficult to manage. NSF is managing. Why is the NSF having the money? All you have to do is to put people who will manage it properly. Oh, peg it to NSSF if it requires so. Now, if Bwindi can do it, why can't government do it?
Organizations like Save for Health Uganda have rolled the health insurance in some parts of the country. The Luero program is the largest, benefiting over 20,000 people. The organization thinks government should change its approach, create a legal framework to regulate and promote community-based health insurance schemes before rolling out the national scheme.
The communities have already shown interest in these schemes. They have been here for the last 25 years. They have not stolen anyone's money. You can go and find everywhere. So we could promote those and reach out to the majority of the population. Then later on, we can harmonize the two groups and achieve our national health insurance. Otherwise, if we continue to think that unless we have the employees and the employers, we cannot start a national insurance scheme, we are going to likely wait for another 10 or 20 years.
Of Uganda's neighbors, Rwanda has embraced universal health coverage at over 85% of the population, Tanzania moving at 32% and Kenya at 18%. Data from the Ministry of Health puts the total annual health expenditure at 7.5 trillion shillings, of which 15% is funded by government, 42% from donors and 41% paid out of pocket by individual citizens when they fall sick. Only 2% is financed through prepayment mechanisms.
It's not acceptable.
Kahara and others are thankful to their community scheme that they are not part of the big spenders on health.
Experts say for the National Health Insurance Scheme to succeed, the sector's funding must be significantly increased to equip the public health facilities, which is possible. And looking at the success stories of the community-based schemes challenges the government that is taking long to provide a universal health program. Edward Muhumuza, NTV.